Hi, I'm Zara McKee, and today I'll be giving my talk, AFOs versus SMOs, what we know about orthosis prescription and provision for children with cerebral palsy. So what is cerebral palsy, or CP? It's the most common pediatric motor disability affecting over 2 per 1,000 births, and it's diagnosed at a really early age. So CP can be diagnosed as early as at birth, but on average between 8 and 24 months old. CP looks really different for different children, as you can see in this image over on the right, but in general, gross motor function is impacted. And so to supplement this, mobility aids are widely used. And one type of mobility aids are orthoses. So there are ankle foot orthoses, or AFOs, and supramalleolar orthoses, or SMOs. As you can see, AFOs are a little bit taller. They offer additional support, and they also can be hinged or solid at the ankle. But both AFOs and SMOs have the same goal of supporting atypical gait. So despite the early age of diagnosis and the prevalent use of mobility aids, there's really limited research on early mobility aid use. So looking at children under 5 years old. And this is problematic because we know that self-directed mobility is really essential for learning and development, not only motor skill development, but also social and cognitive skills as well. And so this motivates our project AIM, looking at what the factors are that influence prescription of AFOs versus SMOs for young children with CP. So this study is a secondary data analysis of a larger mixed method study looking at quantitative surveys and qualitative semi-structured interviews. And the larger study looks at both clinician and parent caregiver perspectives, but this research question and the results I'll be presenting today are really focused on clinicians. So physical therapists, orthotists who make orthoses, pediatricians, all types of clinicians working with this field. And so this first batch of results we have looks at the use of AFOs and SMOs. And we found that AFOs are the most commonly prescribed orthosis. So 79% of clinicians said they most commonly prescribe AFOs, whether that be hinged or solid AFOs, and 21% most commonly prescribe SMOs. And we found similar differing opinions in the clinician interviews. Clinician 13 said they use very few SMOs because they basically don't do anything other than make the family feel like they're doing something. Whereas clinician 24 said if they can get away with SMOs and they still have good coordination, they'd much rather go with less. So liking the reduced support of SMOs. So this really highlights the lack of agreement, the lack of standardization that is across clinicians in regards to orthoses. And we also found some results regarding clinician training and really highlighting it as a major place for improvement. So when asked about experience, clinicians, every clinician said that they had experience with AFOs, and all but one said they had experience with SMOs. But when asked about training, there were 2 clinicians that said they had not been trained on AFOs or SMOs, and 1 additional clinician that had not been trained on SMOs. And so this tells us that there are clinicians who are working with devices that they themselves have not been trained on. And we also know that this definition of training looks different for different clinicians. So for the clinician 33, they described their training as taking webinars, going to classes, going to seminars, but nothing formal in their education. Whereas clinician 32 said 2 of the 7 quarters of their master's program was designated to AFOs specifically. And so it's not only a question of if training is happening or not, but what exactly that training looks like as well. And then our third result group looks at the factors clinicians consider for prescription. And so as expected, physiological factors like range of motion, joint stability, alignment, all were commonly considered factors for prescription of orthoses. But another really commonly considered factor was insurance. And so we know that insurance is therefore, determining or influencing prescription of orthoses, which is really problematic and a big place that we need policy improvement. So the impact and the significance of this study is that it helps with the understanding of the current field conditions and can help motivate future research and policy advocacy, and with the overall goal of developing better standards for prescription and leading to better care and improved quality of life for these children. So thank you all very much, and special thank you to the Ability and Innovation Lab, the Mary Gates Endowment for Students, and NSF. Thank you.